All right, hey everybody, welcome back to SPT with J&Z. I'm Zach Carson.
And I'm Josh Griffith.
Another week that we lagged because of some weekend activities that we weren't able to get to our video. However, this is episode 8 and we are plugging right along. I think we're going to cover weeks 10 and 11 right here. We had quite a few exam type materials, some quizzes and some practicals and some standardized patient things. So generally, we have about the same amount of information as we would on a regular week, maybe just a touch more, so we'll try to get through the video in our standard 40 minutes or so, the best that we can. Do you have any updates?
Missouri's on a roll. They've won like 2 or 3 in a row. They win the last 2 out of 3, they get a bowl.
Nice.
Which is not expected.
But you did mention the other day that their quarterback is like leading the country in touchdown passes,
Yeah.
which is pretty impressive. I know, I could never do that unless I was playing NCAA, which they don't make anymore. So it's
I know. I'm still mad about that.
Michigan is also on a roll. They've went through some pretty weak opponents, but they're 7-2 and should have another win this week. Rolling into Wisconsin. Hopefully we can take down the big beef eaters and cheese eaters out in Wisconsin. I don't know if we mentioned last time, but Houston did win the World Series.
Yep.
Was that part of our last video? Justin Verlander also got married to Kate Upton right following the World Series, and I was like, wow, who's got it better than Justin Upton, right?
Nobody.
Yeah, and he's making $28 million a year, so I'll take 2 out of those 3 things.
Yeah, pretty good day.
Yeah, I'll take the World Series ring and the $28 million.
I would too.
All right, so that is a quick update on non-PT things.
Yep.
Let's go ahead and jump into the PT things. And Josh here is going to lead us off with this awesome anatomy that they have going on right now.
Oh yeah, we have our 3rd exam coming up on Monday. So 3 days of not cramming, but reviewing some things that we haven't gotten to due to other exams and practicals, because you kind of got to compartmentalize what's most important at the moment, and now it's all in on anatomy for the rest of the weekend. But what we've been covering for the most part, for the first half of the semester, we went through the head and neck and the upper extremities. Now we're into the thorax, moving our way down in the body. So we talked about the specific aspects of the heart and the lungs especially, as well as some other abdominal viscera like the spleen, pancreas, liver, and gallbladder. We really looked at those a lot in lab, especially this last week. And of course we looked at the vessels and the innervations of those regions as well. Definitely a lot of layers to the abdomen. That's a lot of the fascial layers is, I would say, probably one of our things that we have to look at the most, because we have piercing questions on our exams where you're looking at every layer of the body, and especially in the thorax we have quite a bit of layers to go through with the abdominal muscles, the different layers of fascia separating those muscles so that we have free movement, and there's even more so in the abdomen so that the organs can move about and not cause any stress on each other. So it's pretty interesting, something that we don't really necessarily think about as much with PT, where we're focused more on the external aspects with all the muscles, but definitely important and interesting, I think, because it's not something typical for us. But we'll move on to kinese. This is a new unit we started on Monday, I believe, because we had our exam last Wednesday.
Yep.
Last Wednesday we had practicals and exam 2 weeks ago now.
And I made the extra credit question.
Did you?
Remember the extra credit question?
Which one?
Where I deadlifted and
Oh,
thrusted
yeah.
my fist in the
You
air.
got put into the question. That was good. I think I got that one right too.
Yeah, that was kind of cool. The extra credit portion actually included like some events of our classmates,
Yeah.
and then some osteokinematic, arthrokinematic applications to what we were actually doing. So our professor is pretty cool in kind of integrating that stuff into the class and making sure that we're having fun and getting the material.
Yeah.
So that's cool.
Anyway, so past the exam now. New unit focusing on the pelvis. A new, bone that I never really thought of or had heard of is the innominate, which I'm still learning, so I can't even build on it that
like
much.
The innominate or the ox coxa is another name for it.
Okay.
There's actually the pelvis. When you look at it and you look at somebody's hips, it's two separate pieces of bone. It's one half and two halves, which is the innominate and innominate. So you have two innominates that completely form the pelvis, and they're basically 1, 2, and then you have on the back you have your sacrum, which kind of creates a joint called the SI joint, the sacroiliac joint, and then in the middle you have down here your pubic bone, which is formed in the middle, and then it has a layer of cartilage called the pubic symphysis. So you actually have 3 moving pieces in the pelvis. You have one innominate, a sacrum, and 2 innominates, and that makes you be able to basically walk, run, do things that you require to in everyday living, because that pelvis moves as a separate entity in itself.
Very good. That's awesome, because what we looked at a lot is the SI joint, its main joint that we're going to be talking about. There's not a lot of movement because it's built for stability, but we do have to have some movement, otherwise we'd have fractured pelvis all the time.
Yes.
So SI joint, like I said, built for stability. It's supported by a lot of ligamentous tissue. The mobility is needed to transfer the stress, like I said, so we don't have a broken pelvis all the time. You have forces coming up into the abdomen, and then same from top down, so it has to transfer those forces right in the middle. If we have hypermobility, a couple of main reasons would be either like pregnancy, hormones kind of cause the pelvis to be a little more flexible, and then also if we have like a trauma where we actually do have some force that causes an injury to it. The osteokinematics of the pelvis, so we can anteriorly rotate it and posterior rotate in the sagittal plane, more commonly known as like an anterior pelvic tilt or a posterior tilt. And then in the frontal plane we have a side bend or a hip hike, and then transverse we can protract and retract the pelvis. And all of these movements are pretty subtle because there's not a ton of movement in the pelvis, but those are the generalized ones. With the movement of the lumbar moving on the sacrum, whenever like the lumbar spine is going into flexion, the sacrum is going to go in like the opposite direction, so it's going to be extended. And then whenever the lumbar spine extends, the pelvis is going to be flexed. With side bending, kind of the same thing. We have kind of moving 2 different ways. So side bending lumbar spine, say this lumbar spine moves to the left, or a side bend to the left, the pelvis is going to bend to the right. So that's like a left hip hike is what it would be termed. And then with rotation, whenever the lumbar spine rotates to the right, we're going to have a rotated to the left for the pelvis to kind of just keep us aligned. So if we're moving this way, the pelvis is going to slightly rotate.
And if you apply that to like walking, it was the example that we were given in class. If you think about when you take a step and your hip flexes, that pelvis on that side is going to compensate by anterior rotation of just the innominate, and then the other one's going to extension, so it's going to go the opposite direction. And not only that, if you think about that, with the pelvis is going to slightly rotate, so your spine has to compensate, because otherwise you'd be walking around like this all day.
Yep.
So basically you're getting a little bit of rotation in that spine to keep your shoulders forward and square. So a lot of things going on kinematically.
Good. All right, then the next segment, I guess, is the sacrum moving on the ilia. Now we have sacral flexion, which is termed nutation, and then sacral extension, which is counternutation, just a different terminology for this structure. Through lumbar spine extension, we're going to have the posterior roll dorsal glide, and then at that time the sacral base is going to move anteriorly, where the apex will go posteriorly. And then in the counternutation, lumbar spine flexion, spine's going to anteriorly roll, ventral cranial glide, and then the sacral base moves posterior, apex goes away anteriorly. In the lower extremity, we have the ilium on the sacrum, and through hip flexion, the ilium does posterior rotation, and hip extension, ilium will rotate anteriorly. And then with the pubic symphysis, it acts like as a pivot, gives some cushioning so that we can have some movement. Otherwise, we'd have two bones just stuck together and not going to be able to flex or move separately. Muscles don't actively move or control the SI joint. They kind of work as stabilization. So just generalize, there's an inner group and an outer group. That inner group is like your transverse abdominis, diaphragm, multifidi, and pelvic floor. Those are going to be your slow fatiguing muscles that are always going to be there for stabilization. And then the outer group are like your bigger movers, like superficial posterior oblique system, the deep longitudinal system, lateral system, and anterior oblique system. And we have more muscles within each system, but I'm not going to go into every single muscle that we have in those groups.
Yeah, and some of those systems work contralaterally and some of them work ipsilaterally. So some of them are kind of like a cross side. So like which muscles do we talk about? The big muscles in the top.
So I think we'll.
Yeah, it works opposite of like the glutes, and then the like the back, the spine erectors, they work on the same side, and then they all work together, obviously, to create that stabilization through the entire midsection.
Okay. And then our last joint that we've covered so far is actually at the hip joint, and it will act similarly to the shoulder, as we have a convex rule there. With flexion, we're going to have an anterior roll, posterior glide, and in that it's a posterior spin since the axis of rotation is going through both surfaces.
Which is the primary movement.
And the primary movement through that is always spin. So spin through flexion and extension. There's also abduction, adduction. So we still have convex roll, so it's going to be either lateral roll, medial glide with abduction, and then medial roll, lateral glide, adduction. And then external rotation and internal rotation as well. External, we'll have that anterior roll, posterior glide, and then internally we'll have posterior roll, anterior glide. Okay. So that covers all of those. With our normal angle of inclination, it's typically at about 125 degrees. With coxa vara, that means that the angle is significantly less than 125, or it's visibly noticeable, because everybody has variation. Not everybody's going to be sitting right at 125, but coxa vara is less than 125, coxa valga greater than 125.
What's the angle of inclination?
You're going to have to tell me on that one, because I am still unsure.
The angle of inclination is the way that the femoral head sits on the neck. So the angle at which the head of the femur forms against the shaft of the femur when it's sitting down. So basically you have your deep concavity and your acetabular convexity here, and or concavity, and then you have the convexity of your femoral head. And some people, they sit in here like this, some people are sitting here more like this, some people are way down here like this. So that angle that is formed right there is going to be the angle of inclination. So it's not always a muscular or ligamentous or tendinous issue in the hip. Sometimes it's just a mechanical issue of how that bone structure is setting together and forming in the pelvis. So those are also things that have to be considered when you have any kind of, I guess, like functional limitations. Yeah, so it's not always like, oh, you can't get into a deep squat. Well, maybe not. Maybe it's not your muscles that are tight. Maybe your joint just is built different than other people's. So that's what that angle is, and can't exactly just measure it in PT clinic.
No, you have to get in there pretty. Just cut off their leg, and then you'll be able to figure it out.
Yeah, that's what we're getting into, right? This is why we got into this profession, cut legs off.
Exactly. Fix it right up, right there. But that covers like what we've done in lecture so far. In lab, we've been palpating the pelvis, and we just went into the lower extremity as well. So more of this, we're in a sensitive area, so we've been talking quite a bit about making sure that the patient is comfortable using correct draping, proper communication with the patient to make sure is it okay if I go ahead and touch around on your the buttock region or on your front side? You really have to make sure that you are comfortable with the client. They have to trust you, and you're not going to go anywhere that they don't want to. Nothing has to be palpated. There's always another way or another treatment that we can choose.
Mm-hmm. Mm-hmm. It's always about the patient first.
Mm-hmm.
Yeah. In these areas, there's certainly people, there's some people who are not comfortable with that regard, but most people will be like, I just want my pain to go away, so like I'm fine. But we always make sure that we take proper precautions by draping the person, or definitely telling them, hey, this is what we're doing. Let me explain to you exactly what we're doing, by pointing to yourself or pointing to it on a skeleton or something along those lines to say, hey, we're going to be working down in the pubic region. This is the area that I'm talking about. There's some muscles, there's some structures down there that we're going to be working on. If at any point you're uncomfortable, please let me know. I'll back off and we'll figure out another way to do this. I mean, it's all about communication.
Patient-centered first. So
the patient is always right.
Yes. And always needs to be 100% comfortable. That's what it's about.
Yeah.
So that kind of concludes what we've done the past couple of weeks with our exam, and then new material and kinese, and then moving on to evidence-based practice with, he's actually going to take that one away for us.
Yep. So the last week we had a quiz in evidence-based practice, so we rolled into that and we got quizzed on like statistical significance, clinical significance, a couple of other things that are kind of slipping my mind right now, but it was based off of just research significance, like intra-class correlations, inter-tester, intra-tester reliability, and then different things that you need to be able to utilize to make sure that your research is valid and reliable, or both, and have quality and relevance to your current situation that you're using it for. I feel like I did okay, but it's very open-ended as far as the way that she conducts her quizzes. They're all written, no choices at all. You just kind of freehand it, and it's
either know it or
you don't.
Really start writing stuff that you think is right.
So hopefully, go team. I did okay on that one. We'll see. Anyways, then we jumped into systematic reviews and meta-analysis. So those are kind of like the cream of the crop of research, and I think we talked about it a little bit about exactly what it is. You have like randomly controlled trials, cohort, case studies, all these different types of studies that kind of go down the ladder as far as how good they are in their quality and relevance. The systematic reviews and meta-analysis are basically like, I'm going to take these 100 randomly controlled trials, and I'm going to give myself a research question, and then I'm going to weed through all of these 100, and now I have it down to 15, and now I'm going to put my inclusion or exclusion criteria in it, and then I'm going to weed it down to 5. Now I have 5 really good research articles that I'm going to conduct a meta-analysis or a systematic review on. So you're not actually doing your own research, you're basically just cherry-picking information from other sources of research to put forth a piece of research that says this is the evidence on this inclusion criteria, and it's strong because X, or it needs help because of Y. So it's kind of a way to just do a general, not a general, it's very in-depth, but a sweep of research and say these are the things that are good and these are the things that are bad about this particular topic. With that, it's to break it down into more of a vocab term, it's the review of a clearly formatted or formulated question that uses systematic and explicit methods to identify, select, and critically appraise the relevant research that's available, and to collect and analyze data from studies that are included in the review. Some of the advantages of that is you don't have to read as many articles. So say Josh or I are working with a patient and we want to know about spinal traction of some sort and its relevance to the clinic and how it can help with low back pain. Just throw it out there. Instead of looking at individually randomly controlled trials or case or cohort studies, we can take a systematic review of all that research that's available and use that instead. Some of the disadvantages, sometimes they have soft conclusions and they say stuff like more research is needed. So sometimes you get that systematic review or meta-analysis back and it's just like the evidence isn't strong enough to conclude the question that I asked. So
Yeah.
it doesn't exactly support the data or get the result that you were looking for. Now, does that mean it can't work in the clinic? Not necessarily, because the clinic is often anecdotal. You can work on a patient, and it might work for one patient, and you try another patient, and it just doesn't work. So everybody's different. You just kind of have to pick and choose those pieces of information that you want to pull, and then from your experiences and what you've done from there, like the patient's goals and everything, kind of just wrap it all together and make sure that you implement the best plan as you can for that patient. I think that pretty much covers it. All we talked about was those reviews. So we've got another abstract to write, so we've been working on that kind of stuff, abstracts, and then just those article appraisals to make sure that we're getting the right information that we need to get out of an article. That's evidence-based practice for the week and going forward. I know we got a couple of papers that we're going to have to write to finish the year, but overall, pretty easy. If you like research, crush it. If you don't like research, get it done anyways.
Yeah.
So let's roll back over to Josh. He's going to cover professional topics for us.
All right. So actually, in a couple of classes that we've been in currently with professional topics, we've been talking about the SOAP notes or our documentation. And we got to do a little bit of documentation in foundations as well, which we'll talk about here in a minute. But we're really wrapping up SOAP notes. So SOAP stands for subjective, objective, assessment, and the plan. So subjective and objective are what you're looking at when you talk to the patient. You're getting their history, and then you're doing some tests on them. And then once we get to the assessment, this is really where your clinical expertise and your critical thinking skills come into play, because this is your impression of everything that's going on with the patient's movement dysfunction and then with the prognosis. Within the assessment, we make some goals with the patient. So this goes by the A, B, C, D, and E's for goal setting. We want to make sure with A that there's the audience or who is going to do it. So the patient's going to be doing the treatment or be performing the treatment.
Mm-hmm.
And then the behavior is what they're going to be doing. The conditions are how are they going to do it. So under what circumstances or conditions will they be doing the behavior. And then the degree is this will measure the behavior and how well that they're actually going to be doing it. And then the last one, E, they did a little mess around with this one, but it's time frame. So the E on time stands for the ABCDE of goals. And the time frame, you have to make sure that you set an estimate of how long that they can attain their goal. Once we've set our goals, then we can make our plan. What intervention are we going to be providing the patient? How often and how long is it going to take to complete their care? Your plan for the further examination on the patient, and then eventually discharge plans and plan to either you're going to refer to other providers or you're actually going to execute a treatment plan for the patient. So that's where we're going to be moving forward in all of our courses. All of that we've done is getting towards a full examination with the patient, and now we're just working on documentation because it's a skill that is specific to PT that we're going to be working on, and we're integrating it into other classes. We integrated into foundations, which we'll talk about now. Zach will take us away. I'm sorry, actually I'll be talking about it here in a little bit. We're going to go into clinical science, and we're going to finish up with what we've been doing in foundations, which is kind of a meshing of everything that we've learned so far.
Mm-hmm.
So Zach will take us to clinical science and talk about how much fun we've had in there right now.
I'm going to take you into a different set of A, B, C, D with an actual E instead of a T.
Okay.
No estimates in this one. This one has to do with moles, which is very fun. All right, so we did have a test in clinical science this week, and so it covered everything from pain, because we didn't get to that the last section. And then we talked about the immune system, and we talked about cancers and infections, different conditions along those lines. So we did have that exam on Wednesday, but I'm just going to give you a brief rundown of what we went over on Monday to finish up Tuesday and Thursday. Classes are all over the place.
Yeah.
So I'm gonna give you a quick rundown of what we didn't cover on the last video, and then so it's pretty short, pretty quick, pretty easy. So the last thing we covered was the pathology of the integumentary system. So we're talking about the skin. Not everybody, I can't generalize with 100% words, but the skin consists of 3 layers: the epidermis, the dermis, and the subcutaneous layer. Each of them has a different function. So we talked a little bit about that, and then we talked about basically skin conditions. The first thing we're going to talk about is moles, and again, those A, B, C, D, E's. So it's pretty common knowledge to know that if you have a mole and it changes over time, you should probably go see the doctor, because it could be skin cancer. Why? Because skin cancer is like the most prevalent cancer in the United States. It's almost a guarantee that you're going to have some form of skin cancer if you're a white Caucasian over the age of 65 years old. And I think I just said white Caucasian, which is exactly the same term,
It's okay.
just with different vocab. So with the A, B, C, D, E's of a mole, the things you're looking for is asymmetry. So if the mole is asymmetrical, it's not a simple round mole, maybe it's kind of like a little bit sketchy around the edges. If it's growing, the borders are ragged or blurred or irregular, that's kind of back to that asymmetry. If the color changes, so it's black, brown, it has a redness to it, that's probably an indication that you need to get it checked out. A change in color over the time, the diameter is greater than 6 millimeters, so if it's growing, and the evolution, which is a change in size or elevation over time. That being said, if you have a mole and you're like, it's always been that big, it's been that big since I can remember, since I was a little kid, it's probably okay. Maybe monitor it just to make sure that it's not going to be changing. So that's my A, B, C, D, E's. My E actually stands for evolution, not time frame. So I feel like that's makes a little bit more sense.
Yeah, it definitely does.
Then we talked about skin infections before we get into the whole cancer bit. The skin infections that you can have a bacterial infection, a viral infection, a fungal infection, and a parasitic infection. So bacterial is the most common. You can have some a folliculitis, like an ingrown hair, cellulitis, which is just basically redness of the skin, maybe hives, something along those lines that basically shows that you have an infection. The body's generally pretty good at taking care of those bacterial infections. Maybe get a little cold, maybe a little sickness over that time, but it can take care of it. Viral infections are a little bit more intense. They're the things like herpes, varicella, verrucas, warts, things of that nature, but also very treatable, and unless you have HIV, which we talked about quite a bit, which is an immunodeficiency, and the antibodies can't actually control that, and you'll have it for a lifetime if you do, in fact, come across that. Fungal infection is something like athlete's foot or jock itch, basically ringworm, things of that nature. Also pretty common. They tend to stick around for a little bit longer, but the body can kick them out with proper treatment. And then parasites such as scabies, and those can be a little bit tougher to get rid of, but they can be treated fairly well. Then if you want to jump forward, we're going to go into skin cancer, so bear with me here as I try to spit out some of this information that it's just very, very dense. There's literally like 1,000 things in this. So I'm gonna bounce around in skin cancer for a little bit, if I can get to it. So as I said, it's the most prevalent in the United States. Nearly all Caucasian people over the ages of 65. Treatment can be surgery, which is generally how it's treated. There's electrodissection, radiation therapy, cryosurgery, like freezing, cutting, room radiation, all those things. You can have several different forms of skin cancer. You can have benign. You can also have malignant. So benign basically meaning that it's well differentiated, it's slow growing, it's encapsulated, and you can remove it fairly well. Malignant means that it's generally growing kind of out of control, and it has a good chance of metastasizing, which means basically it breaks through barriers inside of your body, it gets into your blood, into your lymph, it spreads to other areas and affects other nodes and starts spreading its I want to say wealth, but that sounds like a good term, spreading its disease or its cancer to other places of your body. And then you could possibly, we learned that like the primary site for prostate and other cancers is like in the bone. So if you have prostate cancer, you have a good chance of contracting bone cancer as well. So benign tumor, not good, but better than having a malignant tumor. So if you recognize that you have something, get it treated early. Early and going back for checking up. That's the most important thing. Some of the malignant skin tumors that we talked about was non-melanoma, which included basal cell carcinoma and squamous cell carcinoma, and then melanoma, which had superficial spreading, nodular melanoma, lentigo, acral melanoma being a little bit more serious than the non-melanoma counterpart. So that is basically cancer in a very, very, very small nutshell. Obviously, there's much more to be covered. One other thing that we really covered quite a bit was immunologic skin conditions, and we really hit on dermatomyositis and poliomyositis. Very tough to say.
It is. All these words are so hard to say.
Basically the same thing. Derma is just with a skin rash. This is very, very common. These are the most common idiopathic inflammatory diseases of the muscle, which is pretty bad because they're going to attack those myofibrils and kind of weaken the muscle in the body. However, it's very, very manageable if it's caught early and you are persistent in taking care of yourself. With this skin condition, you could contract a rash for the dermatomyositis, called a heliotrope rash, which is basically like redness around the eyes. You can also get like a shawl pattern around the neck, and then there's also like what's called Gottron's pubiccles, which is like a red, pink, raised area found over the interphalangeal joints of the hand. What else we got in here? So treatment, like I said, it's relatively treatable. Corticosteroids pharmacologically can help treat it. Obviously, you want to make sure that you treat any other underlying cancers, because this is 3 times more likely if you have this skin condition to contract cancer in any other part of the body. So treatment is, like I said, early and often. Talked a little bit about burns. I'm not going to go into depth except for the fact that superficial burns, there's 1st degree, partial thickness burn is a 2nd degree burn, and then full thickness burn is a 3rd degree burn. The worst being full thickness, and you have to be able to treat it, again, especially a full thickness burn, early, quickly, because the body's going to start shutting down different areas if it's not treated effectively. That, I think, is going to be all that I cover in skin conditions, cancers, everything along those lines, just because there's a lot of information there, and that's kind of what I want to cover, and I think it's the most important. But again, we had that exam, so now we're kind of chopping that information and we're moving on next week. Anything you want to add to that class? That was kind of a lot of information.
No, we had, I think like 5 weeks of material that we covered throughout it. So we did have a wide range from, like you said, pain, which is something that's important because every patient that's probably coming to us has some sort of pain because they're trying to get, they want to relieve that pain, and then moving all the way through the skin conditions, we have to be able to recognize something that they may not even be thinking of, like a mole that may be cancerous or something like that. It's just being able to recognize throughout that initial meeting, almost just checking everything out, just to make sure, checking the whole total body. That's what our job is now. So.
Yeah, and I think the biggest thing that our professor stressed to us was if a patient comes in to be treated because they have shoulder weakness, and they come in and they're like, well, I didn't have an injury or anything. First of all, boom, red flag, insidious onset of shoulder weakness without a mechanism of injury. And then all of a sudden you discover that they have this rash on the back of their hand. We might be looking at a systemic illness, autoimmune disorder, and it's not like you're going to be like, hey, by the way, I think you have cancer, because we're PTs, we're not physicians. But you can say, hey, you know what? I see these couple of things, and I want you to go back to your physician and get these things checked out for me. I don't think I can do what you want me to do for you right now. I can't make that shoulder pain go away, and I can definitely do some things that might relieve it now, but ultimately you need to go back and get these things treated. So that's kind of like our job as a professional. We need to recognize these things because we need to refer to other professionals, not just treat musculoskeletal injuries.
Very good.
All right.
Last thing,
Foundations.
So we have practical coming up on, Tuesday, Thursday. Mine's on Thursday, I think Zach's is on
Mine's Tuesday.
And on this one, it's a lot less variation. We're just doing manual muscle testing and muscle length testing, but pretty important because that's how we're going to be figuring out where they have weaknesses, bilaterally or just on one side too. Big thing this week, probably the most clinically applicable thing that we did this week for our short term is a standardized patient. We learned how to take a history on Tuesday, so quick turnaround. Learned how to interview a patient on Tuesday, and then we actually had an actor or a standardized patient come in, and it was like we were in an office and went and met the patient, listened to their concerns, got to know them a little bit as a person, and developed repertoire with them, and just made sure we got down the S on the SOAP note, and then we're going to go back and make the objective portion of that as well. So for me, I wasn't that nervous going in. I mean, we have a set list of questions that we want to make sure that we ask the patient to get generalized information so they can go through with an actual examination. I wasn't nervous at the beginning, but then in the middle of it, I realized I had forgotten a couple of important questions. So I went back to them. I was like, okay, I forgot to ask you about this thing that you had said. Or my patient actually told me about 2 or 3 surgeries they had while I was taking their blood pressure. So they had remembered that, I had rotator cuff surgery on my left arm, but I was looking at his right arm, but he had just remembered that I'd asked him about surgeries previously, and he didn't remember having a surgery that was like 5 years ago. So being able to recall that information that they had forgotten about was important, because while I was doing blood pressure, I had to remember, okay, he had rotator cuff surgery, he's had a hip surgery, he's had these other surgeries as well. And it's just recalling that and just trying to make it a smooth transition is huge, and making sure that the patient's still comfortable, but you're getting all the necessary info that you need to make for your notes in the future. So that was the only time I really got flustered, was when I realized that I had forgotten a couple of questions that I really wanted to get to, because as I was going through my notes, I wasn't necessarily writing a specific note under a question that I had asked him. I was just going through and making sure I just had information. So in the future, I'm going to change up my own template, because I'll get better at asking questions that are related. So instead of having a separate question for how did this happen, where did it happen, how long does it take for it to hurt, I'll just be able to remember those questions and then just put the information down. I won't even have to ask it. I'll just have a heading like mechanism of injury, and basically have everything related to pain. There's pain scale, all of it will kind of just go under that, and then I won't have a full page list of just not random questions, but questions for the patient. It'll be a little more generalized, and I'll just be able to, as a professional, remember what I need to ask based off of the information that they're giving me. And then developing that personal relationship with the client. This is your first interaction with them, so they need to be able to trust you from the very first meeting. Otherwise, they're not going to come back. I mean, even if you give them the best treatment plan and the best exercises and the best care, if they don't feel like you care about them on a personal level, they're probably not going to come back. And vice versa, you may not have the best plan for them at the moment, but if you get a development of trust with the client, they're going to come back, and they're going to be more willing to do what you are providing for them for treatment. So my experience I thought it was awesome, because we got to actually talk with a stranger instead of practicing on a classmate who we're really comfortable with now. So getting outside of our comfort zone was huge as far as developing as a professional. So a really good day. I really enjoyed that. So I don't know about you, man.
Yeah, I'll bounce back on the, the categories thing as you're kind of going through these questions. Like, is there a general format? Some clinics have a general format that you have to hit these bullet points. Some of them don't, and it's a little bit more free-flowing, but the most important part is that we have to get these notes written in order to, send them to the insurance companies to make sure that you're getting billed correctly, that you're getting the right information to refer back to different professionals, things of that nature. So, mine was a little bit similar. I had a couple of headings, but what I did is I knew that I had the information on there, and I didn't necessarily robotically go step by step by step. I knew kind of what the subheadings were, and I said, hey, do you have any pain? And then I knew all the questions that I was going to follow on with. So I would just freehand everything that they told me, and then now what I'm going to do is I'm going to go back and just copy and paste those things into the headings that correctly need to be in. But it's nice to have those headings because then, like you said, you can go back and say, okay, 1 second, let me make sure I didn't miss anything here, and then oh yeah, I missed this heading. Let's talk about that for a second. And again, as long as you establish that open dialogue with the patient that you're working with, you might miss something, you also might gain something that you didn't think you were going to get, but at the same time, when you're talking to them about different things along the line, you might get a little tidbit of information that leads you to believe you need to go back and talk about another heading or another piece of information again and kind of revisit that information. And we do that also at the end when we do our summary. We say, all right, this is what I have so far. Let me just make sure that everything that you've told me so far has been covered, or if there's anything that we've missed, and you kind of summarize everything you've talked about. And then maybe they're like, oh, well, actually, this, and this happened too. And you're like, okay, thank you for that information. And then you can go forward from there. So, the basic information of that visit is going to be like, hey, I see that you're here for this. Let's talk a little bit about that information that you have. And then maybe, dig into their past a little bit to make sure that there's nothing underlying, and then injuries that may have built up to this moment, or maybe they have some kind of systemic illness, and those are the things that we need to understand or be able to see when we're writing these notes, so we can, again, treat them accordingly or refer them accordingly. So yeah, mine was pretty good too. I had no problems going through it. The debrief went really well. She was very pleased with the way I conducted the interview. And again, like you said, it's a great learning experience working with people outside of the people that we're comfortable with. I know for me, I've been working with clients as a coach and as a strength and conditioning coach and as a personal trainer for the last couple of years. That helped me segue into this. It's simply being able to ask the right questions. I'm pretty good at talking to people, but being able to get the information that I need out of them depends on the information that I have up here, knowing what I need to do professionally. So that's the biggest thing for me.
I'm looking forward to being able to do more opportunities like this and using the skills that we've been learning in foundations. Those are what we're going to be doing every day. Foundations of PT examination is the name of the course. So, yeah. It's building our skills for everyday use, and it's cool that we can see all the classes coming together to be doing our job now. It's not just bits and pieces now. It's starting to come full circle even in the first semester. So, pretty cool experience yesterday.
Yeah. And again, it's one of those things like first year. Obviously, this is just the first semester, but the first year is kind of like this wide-ranging foundation. And then we're going to start putting the blocks on the pyramid and slowly work our way up. So it's kind of just like, here's the general information for everything. And then later we're going to get the specific information for the blocks as we work our way into our professional careers. And actually, that pyramid's probably never ending.
No, never. Because we're going to be we're going to learn things now that may become outdated with something better. We may find something better, a better way to do it. And based on the clinic, you may not even have the same tools that we've been using either. It's going to just depend. So it's a foundation, but then we're going to build on these skills that we've had. We're going to go to conferences. We're going to learn all kinds of new information that will just integrate into what we've already learned. So it's you can't ever be complacent, forever learning, always learning to make yourself better. So.
All right, you have anything else?
That's all I got for this week.
All right, excellent. Well, hopefully we'll be back next weekend.
Sounds good. We should make it.
All right, thanks a lot for watching, guys. Have a good day.
Have a good week.